Good evening, everyone. Welcome to this meeting. The nurses group of Global Initiative for Children's Surgery. We welcome you all to this webinar, which is on intraoperative care in pediatrics. And this webinar is hosted by GICS and conducted by the Christian Medical College, Vellore, India. Just as a start of the seminar and an introduction, I just would like to share the objectives. This webinar is arranged so that we'll be able to ultimately provide optimal intraoperative care to surgically ill children. With this aim in mind, we have these objectives under which we have collated our presentations for today. So the objectives are as follows. We will be reviewing and updating certain aspects, especially aspects of managing children's anxiety and fear, and also delivering safe surgical care in OR, and addressing specific intraoperative needs for children, understanding anesthetic needs, especially in children who are undergoing surgery, and providing optimal PACU care. These are the aspects that we are going to cover under the intraoperative care to surgically ill children. And we have experts from CMC, different departments and disciplines come here, who will be sharing through their experience the points that we have to take home today on these different aspects. Although the plan was to start with anxiety and fear in children, the order is slightly changed now. We will be starting with delivering safe surgical care in OR, and the anxiety and fear will be dealt at the end. Moving on to introduction. So we will be starting our webinar with Ms. Daisy Shiba talking on the surgical safety of children in OR. To introduce her, Daisy Shiba is a charge nurse in the operating room of Christian Medical College and Hospital, Vellore, and she has completed her bachelor's in nursing, and she has worked in pediatric surgical operating room for a pediatric operating room for many years now. And her area of interest is giving optimal care for children who are undergoing surgery, and is very passionate about it. And now I hand over the session to Daisy to take us through the safety of children in OR. Over to you, Daisy.
Hello, ma'am. I'm audible.
Yes, you are, Daisy. Go on.
Yes. Hello, everyone. Today, I'm going to present on surgical safety in children. Surgical safety. Surgical safety unintended harmful during healthcare delivery has increased dramatically in recent years, with the figure of 10% of hospital admissions suffering an adverse event now being generally accepted. Surgical care poses unique risk to patients, with approximately 50% of untoward surgical outcomes occurs in the operative phases. Given the obliquity of surgery, this has significant implications. The report crude mortality rate after major surgery is 0.5 to 5%. Complications after inpatient operations occurs in up to 25% of patients. In industrialized countries, nearly of all the adverse events in hospitalized patients are related to surgical care. At least half of the cases in which surgery lead to harm are considered preventable. Mortality from general anesthesia alone is reported to be as high as 1 in 150 in some parts of sub-Saharan Africa. Coming to my topic, it has divided into 3 categories. One is safe perioperative environment and safe procedure and safe personnel. In the first, it is vital parameters and the surface disinfectant and microbiology surveillance. Zoning of OR is to be followed. In vital parameters to be maintained inside the OR, first the temperature is maintained 21 plus or minus 3 degrees centigrade. Mainly in pediatric, 26 to 28 degrees centigrade is followed. And the humidity 20 to 60% is maintained. Pressure, positive pressure above 2 Pascal is maintained. Air exchange 20 to 25 per hour is maintained. And also laminar airflow must be present to remove all the organism and maintain the positive pressure. Then HEPA filter is used. High efficiency particulate air filtration 0.3 micron is filtered in this HEPA filters. Then carbon dioxide above 1000 ppm is maintained inside the OR. Then come to surface disinfectant. High-level surface disinfectant with the hydrogen peroxide and silver nitrate combination must be used to disinfect the surface in the operating suite. There are four times we are doing this surface disinfectant. It starts from the day, in the early morning, before starting the OR. First case, the start of cleaning is started. Then in between the cases, the surface disinfection is carried out. Then terminal cleaning at the end of the day, thorough cleaning must be done, and all the walls and the floors is cleaned, and all the equipments which are available in that particular theater is cleaned thoroughly and maintained. Then weekly, we are doing deep cleaning and preventive maintenance must be carried out. Then coming to bloodborne virus thing, HIV positive cases, 1% sodium hypochlorite for all surface cleaning, instruments cleaning, and linen cleaning is used. So everything is soaked 20 to 30 minutes. It has to be soaked with the 1% hypochlorite. Then first autoclave has to be done, then the washing, then arranging, then again second autoclave must be carried out. Then HbS-Ag positive, the floor is cleaned with 1% Virex. High touch surfaces, 20% microsheet is used. Instruments, 10% Virex is used to soak the instruments. Again, linen, all the blood linen, 1% sodium hypochlorite is used to clean all HBS virus vaccination cleaning. Then coming to microbiology surveillance. Microbiology surveillance must be carried out every month. Action must be approximately taken in case any growth is present. Swabs and settle plates are used to collect these micro surveillance is done. Then micro technician perform the swabs. and the HICC nurse supervise it, and this has to be carried out in every month. Coming to zoning in war, there are 4 zonings we are following. One is unrestricted zone. There, the unchanged person are entering. Then in the transient zone, the changing room, there the personnel change their, they will don the scrubs and they will enter into the semi-restricted zone. In semi-restricted zone, only limited people are will be present. Restricted zone, the surgery operating suite is considered as restricted zone. Then in the surgical safety checklist and surgical count is count to be done in the procedure, safe procedure. In safe procedure, surgical safety checklist, surgical safety checklist to avoid unwanted errors in the patient in operating suite. It has few benefits. The checklist helps to improve patient safety by reducing the risk of adverse event. It has been shown to implicate the mortality by over 30%. It helps to identify patient correctly before the surgery, which reduce the risk of wrong patients. Here, you are following in 6 phases. One is sign-in phase 1. In sign-in phase 1, the ward nurse and the holding nurse will be there. The patient will be brought into the holding bay. The ward nurse will initiate the sign-in phase 1. The ward nurse will read the ID band of the patient. The holding bay nurse will check in the patient chart. Then surgical marking is checked. Surgical procedures will be confirmed, and the consent of the anesthesia and surgery will be checked and signed by the ward nurse as well as the holding bay nurse. Then in second phase, surgical sign-in phase 2, the particular theater anesthesiologist and the circulating nurse will come to the holding bay. The anesthesiologist will be initiating the phase 2. The patient is identified. He will be reading the ID band of the patient, and the the circulating nurse will check in the chart. Surgical site is marked, and the surgical procedures will be confirmed, and the consent of the anesthesia and the surgeons, they will confirm, and they will be signing in the both in the same column, anesthesiologist and the circulating nurse. Then come to timeout procedure. This patient will be wheeled into the OR suite. Before transferring the patient on table, the circulating nurse will initiate the timeout procedure. The surgeon will be checking the ID band. The circulating nurse from the OR list and the chart, she will be reading the patient identity and the surgical site and patient what the patient is posted for the surgery will be confirmed in the presence of surgeon and the scrub nurse. Then surgeon, anesthesiologist and the circulating nurse will sign and complete. Then the patient will be given anesthesia and patient will be positioned. Then after draping, cleaning and draping, the surgical pass will be initiated by the surgeon. The surgeon will give the brief about the patient name and hospital number and the surgery, what he is going to proceed and how much blood loss they are expecting. That will be short communicated to the team. Then the anesthesiologist will be tell about the prophylactic antibiotic, whether it's administered, and the number of points of blood is available in the theater. Any blood is arranged in the ICU. All the things the anesthesiologist will verbalize. Then the scrub nurse will verbalize about the baseline count of sponge, swabs, and sharps, and surgical instruments will be communicated. And the circulating nurse will connect all the diathermy and the suction, and she will be telling that reading. Once this is completed, then patient surgery will be started. Then at the end of this surgery, sign out phase 1 is confirmed. It is before closing the sign out phase 1 is confirmed. The first count is taken prior to muscle closure, and second count will be taken prior to closing subcutaneous, and the final count prior to skin closure. Then after skin closure, counts are taken. It is initiated by the scrub nurse. Then scrub nurse, from the site of the surgery, she will start the counting. Then the sterile table side. Then the circulating nurse will take the counts and she will explain. Then they will be confirming sign out phase 1. Then come to the patient will be, surgery is completed and patient will be shifted to PACU, post anesthesia care unit. Then after the patient is fully awake and recovery from the anesthesia, the anesthetist will come and write the discharge and patient will be moved to ward. The ward nurse will come to the PACU side. In the holding bay side, the PACU nurse will initiate sign out phase 2, and she will tell about the patient identity and confirm. Then relevant report will be handed over to the ward nurse. Then PACU nurse will sign and ward nurse will sign. This is the surgical safety we are following in the pediatric data. Then come to surgical counting. Swab, sponge, surgical instruments and sharps are taken. These are the 4. The initial count must be taken when the tray is packed and sent for sterilizer. The initial person will arrange and she will take the counting, along with the counter signature must be done with the next person. Then before opening the surgery, skin incision, the baseline count must be taken. The scrub nurse will take, and circulating nurse with the Kodak system will follow and take the swab, sponge instruments and sharp counts. Once the surgery is finished, before closing the cavity, first count is taken. Then before closing the muscle, the second count is taken. As I said earlier, from the surgical field to the sterile trolley, then the circulating nurse will be confirmed. 4 counts will be confirmed. Then the sponge board is used to write all the details of what all the things they have given to the surgical field. It should be entered in the surgical board. Then there is a permanent record we are following, that is the sponge record documentation will be done and signed by the circulating nurse. Then the charge nurse also will come and verify the count. Then sponge racks is used to display the obvious counts. Then come to the safe personnel. In safe personnel, there are 4 cadres. One is war attire and surgical scrubbing, gowning and gloving, draping of the trolley of the patient, and neutral zone is followed. In war attire, once the staff enter into the transient zone, they will be changing their outside dress to the war suit. First, they will change the cap. The cap is done. Then surgical dress, which is surgical scrubs, will be done by the person. Then shoes are clean and dedicated for use within the perioperative environment. That shoes will be worn. Then finally, the mask will be tied by the person. Then she will be entered into the semi-restricted zone. So war attire is most important, that will be followed. Then the surgical scrubbing, gowning and gloving must be done. In surgical scrubbing, bar below elbow is followed. Then no brush. First scrub must be proceed with a hand hygiene procedure, that palm to palm, palm to dorsum, left dorsum and right dorsum, interlace, interlock, thumb rotation and fingertips and the wrist rotation is followed. Then after that, they will be taking the antiseptic solution. 3 to 5 minutes contact time is followed. Then with povidone iodine and chlorhexidine 2% solution will be used for surgical scrubbing. In surgical gowning, reusable and disposable gowns are used. Gowns must be wrapped around to cover at the back of the personnel. Then gloving. There are two gloving technique, open gloving and closed gloving. And closed gloving technique is followed in our theaters. Draping of trolley and the patients. Place drapes on the dry area, allows sufficient time to permit careful application, allows sufficient space to observe sterile technique, handle drapes as little as possible, carry folded drapes to the OR table. Then the neutral zoning is followed to avoid unnecessarily injuries. The neutral zone is a designated area for staff members to pass sharps, example instruments, blades and needles. It can be on the Mayo stand or created using a transfer device such as a magnetic pad or basin. Sharps are placed within or on the neutral zone after each use during a procedure with verbal notification of this placement. The objective of the neutral zone is to confirm that the sharp is only being handled by one team member at a time. For take-home message, to ensure safe surgery, we must maintain a safe perioperative environment, ensure safe procedure are carried out, adhere to the policies and protocols of war. Remember, we are the advocate for those tiny tots who are highly vulnerable. Thank you.
Thank you, Daisy, for your presentation on surgical safety, which is a very important aspect of intraoperative care. You elaborated on 3 important aspects on the safety, and we thank you for your presentation. Can you stop sharing? And
yes,
thank you.
Thank you.
Before the next panelist starts her presentation, because more number of participants have joined, I just would like to share my initial slide again and give some important information on today's webinar. So today's webinar again is a webinar of the Nursing Working Group of Global Initiative for Children's Surgery. Welcome you all once again for this webinar on intraoperative care in pediatrics. We are going to look at different aspects of intraoperative care today. We look at anxiety and fear in children, surgical safety, children's intraoperative needs, and perioperative anesthesia and discharge from post-anesthesia care unit. I request all of you to wait or place your questions in the chat box. I will, at the end of all the presentations, we will look at the chat box for questions, and I will ensure the questions are directed to the right person so that we can have answers. So during the presentations, there will not be generally question answer session. We will continue the presentation one after the other. If there is any urgent need to stop at any time, again, please put that on chat. We'll make sure that that is your concern is addressed immediately. Thank you all. Welcome once again. We'll move on to the next presentation. Sorry, I have to share. Introduce. We just heard Daisy, and now we'll go on to the next topic of ours, children's intraoperative needs. To take the session, we have Dr. Susan Jahangir, who is a professor in pediatric surgery at the Christian Medical College, Vellore. She has completed her MCH in pediatric surgery. Her areas of interest is burns, stem cell therapy, pediatric oncology, and research. She is an ardent researcher as well as a very, very dedicated clinician, surgeon. So we are very happy to have Dr. Susan here to talk to us on the specific needs of children during the intraoperative phase. Over to you, Dr. Susan.
Thank you, Vinita. I hope you can see my screen.
Yes, we can. Yes.
So today we're just going to go through some of the things that we need to keep in mind when we're introducing a child into the operating theater. And these are just a few aspects that I've covered. I may have missed some. You can add on to them as we go if you feel fit. So these are some of the aspects which we will cover today. We'll start with discussing the operating table. Before the child comes in, it is always good to discuss with the entire team what are the parts of the table that will be required, if there is a need for an extension of the table, if the child is very small, do we need to shorten the table? If II is going to be used, what part of the body needs to be in the II compatible zone. And I think just a discussion with the surgical team and with the anesthetic team at the beginning of every case makes everything very smooth. And you can discuss what is required and keep it ready before the child comes in so that there's no confusion when the child actually is inside the OR. Of course, I don't need to go into cleaning and all of that all over again. But if there is, once you have prepared and got the table ready, it's very important to put some warm sheets on it and put the warmer onto the bed with smooth sheets so that the child will be placed onto a warm bed when it comes into theater. If there is a small baby, you can see these areas where there are holes in the table. So we need to adjust our placement of the child in such a way that a small baby doesn't fall into that crack. Then we'll come to patient transfer. So once you have the baby come into theater, it's always nice for the baby to come in with a parent into the induction room. And it's nice to have toys and noisy instruments, bubbles, things that child life therapy technicians use to distract a child from the anxiety of coming into an unknown area. And it's also nice when the parent dresses like the surgeon so that the child doesn't feel like there is something else going on here that they are not part of. So while transferring, once the baby has gone off to sleep, a lot of our anesthesia technicians will engage the child and get them to put the mask while they're sitting or even while they're being carried around. And once the child is under, then the mom or dad, whoever has accompanied the child, can leave the theater. Transferring the child into the theater, it is important that the trolley and the transport trolley and the OR table are both locked before transferring the child. And there are two people on either side of the baby at all times. To transfer an older child, you need 4 people to assist. And while transferring an anesthetized child who has been anesthetized already in the induction room, the anesthetist guards the tube. We all know this. And the anesthetist is the one that initiates the transfer. Surgeons are usually responsible for any unsplinted fractures, any parts of the body that need to be carefully transferred, a large tumor on the leg, whatever. Any part of the body that is not stable is the responsibility of the surgeon. Before starting the operation, we usually do a timeout. This will be initiated by the surgeon before the incision, and it is a loud verification of the identity of the child, followed by the procedure that is planned, and whether or not you have an ICU bed available. Check with the anesthetist whether antibiotics are given if required. Confirm that there is blood in the theater. The scrub nurse usually will confirm that instrument and mop counts have been taken. All, all activity in the theater usually stops for a few minutes while this is done. Before the start of the procedure, it's important that we put the cautery plate on in a safe manner. So the best way to put a cautery plate to avoid any cautery plate burns is to avoid any bony prominences, avoid any metal implants, any prosthesis, um, any scar areas. Where there is too much hair, the cautery plate's contact will not be good enough. And in any pressure areas, if you're going to turn the baby over, you need to avoid areas that are going to be under pressure so that there is no ischemia and there's no pressure on the surgical cautery plate. Now, we have to also ensure that the cables of the cautery, that there are no breaks in the cables, and that there are no areas of the cable that are overused, which might expose the wires inside. Um, Ensure that the child doesn't have any jewelry on, which may be metallic and might cause the current to flow through that area in the body. When placing the child and with the use of cautery, we have to make sure that the child's body is not in contact with any metal, either on the table or on any of the parts of, like if you want to put up a stirrup, make sure that the child's body does not touch any metallic parts. And while using a cautery, it is always good to have a smoke evacuation going on for the safety of the surgical team and everyone else around in the theater. Positioning of the patient is very important before starting any operation, and we use several devices and stuff to position patients. You might have these lovely ready-made gel pads, but they're not really necessary. If you don't have them, you can easily use just a soft roll or use a pressure bag. Like a lot of times we do use a pressure bag to elevate the shoulders rather than put a hard roll underneath. So there are ways to use any soft roll. You can use sponge, you can use anything that is soft that will protect the body from any pressure during surgery. The other thing is, when you have a long operation going on, it's necessary to reassess these areas of pressure. So it might be a good idea to massage the head, to massage the feet from under the drapes at regular intervals to avoid complications, which I'll show you we've seen in our own patients. So in the supine position, these are the pressure points. As you can see in the picture, the heels, usually the shoulders, and the back of the head as well. In this child, there was a bit of alopecia from the pressure from the ring during a long operation. So that's why after this we have started massaging the head so that one pressure point is not um, exposed for a long time. Also, when you are in supine position, we have to ensure that the arm board is not higher than the level of the table, that it's at the level of the table, and you don't lift the arm more than 90 degrees above the level of the shoulder. These all can cause the nerves to stretch and can cause nerve injuries. The other thing we use is an ether screen. This is just a simple metal rod over which the drapes go so that uh, the tubes and the anesthetic apparatus that is under the drapes is not disturbed by the surgical team. This is these are the pressure points in the lateral position. There are a lot of pressure points to be aware of. You need to have an axillary roll under the axilla so that you can take pressure off from the axillary nerve. The ears need to be protected from pressure. The hips need to be protected, the knees and the heels, of course. And here you can see that in one of our patients, in spite of doing all of this, we still had, because this child had an 8.5 hour operation, there are pressure points that developed during this operation, which can be quite sore and painful afterwards. In the supine position, we need to take care first of the ET tube, make sure that the tube position is uh, good, that the eyes are not under pressure, and then, of course, external genitalia, knees, toes, and other things are protected as well. You need to also make sure that the abdomen is free so that ventilation is good. Uh, this is a common position of lithotomy. And here, usually in a baby, we have the arms going down. So that's why we need to make sure that this part of the metal lithotomy stirrup does not touch the arms, and the arms are covered with soft roll so that no part of the body for the child is touching a metal part. The other points of concern here would be the common peroneal nerve and the posterior tibial nerve, which can get compressed at the joint. So always we need to have some soft rolls underneath, even if it is a padded stirrup. When we have positioned the child, we need to recheck all of these things which were done in the supine position. So check the airway, make sure that the endotracheal tube is still in place and your child is ventilating well. Make sure that all the monitors are reading well, that your lines, this line you can see, there's a large extravasation at the end of the operation, which went unnoticed because the child was in lateral position. That the eyes and neurovascular bundles everywhere have been padded and taken care of, and that cables, catheters, electrodes, whatever is passing is checked and rechecked before the drapes go on, so that there is no risk of pressure on the child's body and there is no risk of burn. As I was saying, you need to, if you need to use an imaging intensifier, there is the proper lead gown which needs to be donned properly. It can't be sagging and hanging off like this lovely gentleman over here, but this person has worn it nicely, it fits well, and she's got a thyroid collar as well. You need to drape this part of the image intensifier that goes above the table, that's the green part, with a plastic wrap. And these can be just simple sterilized plastic wraps. You need not buy the ready-made ones. The one down, we don't bother to drape because that goes under the table and that's not sterile anyways. The table, as I was saying, needs to be positioned. The child needs to be positioned on the table in such a way that the image intensifier can be used easily. And these are things that will be easier if there is a discussion at the beginning of the operation. Now, if you have put catheters, if the surgeons have inserted intra-abdominal catheters, a chest tube, any urinary catheters, it is always good to label them. And the nurses, usually our theater nurses, floor nurse, will then hand over to the recovery nurses and talk about each catheter and what they are meant for and the importance of each one of them. And I'm not going into catheterization that much, but sterile technique needs to be maintained, and it is a no touch technique um, when we catheterize someone. And the important thing while catheterizing is to make sure that you don't inflate the bulb before you see urine. Now, what is the role of the nurse in a sick child? When you have somebody who is in theater getting sick, there are a few very key roles which the floor nurse can take up. Number one would be timekeeping. You need to quickly on the board jot down the time of arrest and what is happening after the arrest, the time when the adrenaline was given, the time when the CPR was started. If you start using amiodarone, what time that was started. Ensure that the counts are correct at that point, because in all of that confusion, definitely um, counts can be the last thing that we think of. Yeah. So make sure that there is a count taken by the scrub nurse at that point, and ensure when there is a large transfusion going on that the blood products are correct. This can be done by the floor nurse while she maintains a calm disposition in a panicky situation. So when we're talking about blood products, we need to maintain the cold chain, right? Um, Check for the cross match record. We need to check the blood group, RH type, child's name, the ID band, hospital number, and expiration date of the blood. Also, we have to make sure that fresh blood products are transfused within 30 minutes, and uh, if not transfused, they need to be stored in blood refrigerators. Red blood cells and plasma usually will not be good after 30 minutes at room temperature. So they need to be quickly transferred to a blood refrigerator. Albumin can be kept at room temperature for about 24 hours. So the surgical team needs to support each other by maintaining a quiet atmosphere within the theater and make sure only the required personnel are inside the theater and it's not a crowded affair. Um, if the operation is going on for a very long time, maybe the floor nurse can ask for permission from the surgeon to update the family, in which way we can support both the surgical team and the family. In spite of all our good efforts, horrible things do happen. This is a bare hugger burn in a small child undergoing a thoracic operation for about 8 hours, and this is a very, very deep burn that happened. These are blebs that have occurred on the cautery plate. Uh, so we need to constantly monitor our devices because they are devices in the end and they can malfunction. Okay. And if you think that something is going wrong, always communicate. Communicate your fear, communicate your um, doubts. And that way we can constantly monitor, reassess, communicate, and keep children safe. Thank you.
Thank you, Dr. Susan, for taking us through that intraoperative period, actually, and um, sharing some of the important points that we have to keep in mind, especially when the operation is going on, and the aspects that we have to remember and check. Thank you for reminding us on that. I don't see any questions on the chat yet. So I encourage the participants to put down your questions or doubts or even points that you want to add in the chat so that we can look at it at the end. Thank you once again, Dr. Susan. We'll move on to the next presenter. I will share my introduction slide again. We have the next presenter is Dr. Anita Shirley Jocelyn. She will be talking about the anesthesia needs and what we have to remember in terms of anesthesia for children who are undergoing surgery. And I'm sure she'll bring out all the different aspects that we have to keep in mind as far as not only the surgery is concerned, but also on the anesthesia side. Dr. Anita is a professor and head of pediatric and OB/GYN anesthesia unit at the Christian Medical College, Vellore. And she has completed her MD and DNB anesthesia and also a fellowship in pediatric anesthesia. Pediatric anesthesia has been revolutionized and has improved so much after she has taken over, and she contributes so much to the anesthesia needs of our children. Her area of interest, of course, is pediatric anesthesia, quality improvement, and pain management, especially in children. She's very passionate about teaching safe anesthesia, and anytime we call her to talk to us about safe anesthesia, she's ready. And here she is. Over to Dr. Anita. Over to you.
Thank you, Sister Vinita, for those kind words of introduction. A very good evening to all of you. And before I begin, I would like to thank the GICS Nursing Working Group and Dr. Vinita Ravindran for organizing this excellent session, and also for giving me the opportunity to connect with all of you. I would like to bring greetings from the Department of Anesthesia at CMC Vellore. These are our two main campuses. So the topic given to me is the intraoperative care of children during surgery. Now, before I begin, I just want to explain the term perioperative period. So even though we talk about the intraoperative period, that is a time when the child actually is undergoing surgery inside theatre. When we say perioperative period, this is the period which covers not just the intraoperative period, but also pre-op and post-op. And we say this is a continuous phase, because you can't separate one from the other. In other words, how the child is prepared or assessed and optimized pre-operatively will determine how the child does intraoperatively, as well as the pre-op and intraop has a significant impact on the post-operative outcome and the recovery of the child. So that's why I mentioned it's a perioperative period is a very continuous phase. Now, so the other important thing to keep in mind is children are different. They are not like adults. So very significantly, if I have to point out one important difference, it's because their reserves are very less and their requirements are more. That is, children, especially the smaller children, their cells are rapidly metabolizing because of their rapid growth, as well as if you look at their organ systems like the lungs or the heart, their reserve is very less. So what is the implication of this? Basically, if there is any insult, in case a child is having any complication, the way they deteriorate and they crash is very, very, very fast as compared to an adult patient. So it's very important for us to be prepared to know, anticipate all the complications and take care of the child. Okay, so that is how a child differs significantly from an adult. Okay, now to take you through the perioperative period, how the anesthesia care works, or how as anesthetists we are involved in the care of these patients, I would like to introduce this case scenario where let's talk about Kevin, who's a 4-year-old boy who's coming for an elective surgery, erythroplasty surgery. Okay, we'll see how this child is going to undergo anesthesia through all the 3 phases. The first thing is important for me to know whether Kevin is, fit for surgery. So obviously that starts with assessment. So if you look at any clinical area, we always know history examination comes first. So same way anesthetists, we inquire about the history from the parents, or if the child is bigger, we talk to the children. So basically they don't need too much of detailed history because they don't have much comorbidities like adults. But most importantly, it's very important to pick out whether the child is having any active respiratory infection, because it's very common. I'm sure all of you agree, especially in a developing country where there's so much of population, so it's very easy for the child to get these recurrent respiratory infections. Now again, do we cancel or not accept all respiratory infections? The answer is no, because respiratory infection again comes in a huge spectrum. If the child is looking healthy and there's just minimal kind of a running nose, then you really don't need to worry about it. But it's important to see who's a sick child. So it's very you see whether the child has fever and whether the child is very lethargic looking. See if there is any fast breathing. The child visibly is kind of tachypneic, and you can ask the parents. They give you very good history that the child is not the usual self, child is not feeding well, then this is not safe to accept the child. Now auscultation and looking for any murmurs, all these are very important when it comes to examination. Then we look at the investigations. Now again, as I said, we don't need a battery of investigations for a child, especially if it's coming for mild or moderate surgery. All you need to know is a hemoglobin to see whether the child is anemic, and probably viral markers as per the institutional protocol. Apart from that, you don't need any other investigations. Then once you do the assessment, the examination, and look at the investigations, then it's time to speak to the parents about the anesthesia plan. So we tell them what is the mode of anesthesia, what as parents they expect for the child to undergo during the intra period, and also what is a pain management plan. So everything you inform, and what are the possible complications following anesthesia. And once all this information has been provided, then you get an informed consent which has to be properly signed and with a date and time, and that is because the anesthesia records are very important legal documents, so it's very important to get all these things in a complete manner. Now, the next important thing in the preoperative period is the preoperative preparation of the child. Once you kind of, accept the child, next you need to prepare. So now little Kevin is being accepted for surgery. Next, I need to, give these clear instructions to the parents. So first thing will be the fasting guidelines. So you do not want any stomach, contents in the stomach, like, solids or milk or fluids. So we have these very clear fasting guidelines given by the American Society of Anesthesiology. So any light meal or non-human milk that you're talking about, the cow's milk or the infant formula, it's basically had to be given at least 6 hours prior. Breast milk, because it has more water content and very easily digestible proteins, you can actually give for a smaller baby, for the mother to feed the baby at least 3 hours to 4 hours prior. On the other hand, clear fluids, that is, water or glucose water or one of these non-pulpy juices, the child can actually take it 1 to 2 hours prior. Now for Kevin, all this, breast milk does not apply. So it will be the meal and the clear fluids orders will be provided as per the surgical time. Now next is the pre-medication. Now pre-medication is again not mandatory for all children. Pre-medication again depends only on the age of the child and whether how anxious the child is during the preoperative visit. Now children less than 1 year generally do not have stranger anxiety, so you do not need pre-medication. Similarly, children who are more than 5 or 6 years, if they have normal development, then again you can speak to them, they'll be able to comprehend, and especially if you tell them, the parents can accompany up to some extent in the operation theatre. then again their anxiety can come down, so you don't need a pre-medication. But this age group of about 1 to 3 to 4 years are somebody who, they really have lots of stranger anxiety, and it's very difficult to build a rapport with them. So at that point, or if the child has had a very negative experience during the previous hospitalization, or is very clingy and crying and not being able to separate from parents, all these you will be able to assess during the preoperative visit. Then it's better to pre-medicate, and we have different groups of drugs, and each of them, either you can give it orally or intranasally. The onset of action differs for each of these routes. What is more important is you need to know what is available in your center, what is the dose of it, what is a safe dose to be given, as well as what are the known complications. That is important to know, and because most of these sedatives, if you give it especially at a higher dose, there is a chance that child even can have decrease in respiration and apnea and can become hypoxic. So it's very important to know what drug you're giving. Now, on the other hand, if it's a major procedure, it's important to arrange for blood or blood products or ICU for post-op care in the preoperative, the previous day itself. Now, for this surgery of erythroplasty, this will not apply, but it applies for a sick child or for a major surgery. Okay, now next we are going into the intraoperative period. Now this is a major chunk, where the anesthesiologists are going to be present inside. And again, there are various components we need to look at when we say intraoperative anesthesia care. So the first and foremost thing will be to be prepared before we take Kevin inside the operation theatre. Now, as I already mentioned, the child's reserves are very less. So in case, there is a temporary period where the child stops breathing and you're not able to put in the tube inside, the desaturation is going to be very significant and very faster as compared to an adult with the same period of apnea. So it's very important to have age-specific correct equipments available before you start, and all of them should be working. And especially in centers where it's not a freestanding children's hospital, if it's a place where you do adult and child together, it's all the more reason before you start ensure that the child, the age, as per the age of the child, all the related equipments are available. And generally, if you see adult, most of the time it's just one size laryngoscope or just a similar kind of endotracheal tubes. But in a child, as per the age of the child, it's it varies. The neonate, it's drastically different as compared to a 3 or 4 year old child. So again, it's very, very important to ensure that correct equipments are available. Now, in addition to the equipment, it's also very important to have a clear airway plan, anesthesia plan, what you're going to give, what drugs. And as I mentioned, the smaller, say a 2 or 3 kg baby comes, you can't just have the drugs loaded as per the adult dilution. You need to dilute further so that you have the appropriate dilutions available. Similarly, airway plan, all what gadget you're going to use, everything has to be checked and kept ready, and don't forget your suction catheters. In addition to all that, it's always nice to ensure that you have an experienced anesthesiologist available to take care of the child. Before all these are prepared, do not take child into the OR. Now next, when Kevin comes into the OR, he will be received by the holding bay nurse, and they are made to wait in the patient holding area. Now this patient holding area, as you see, it is beautifully colored, and lots of pictures are there. And this is a place where the child and the parents do come and wait. And even if the previous surgery takes a little bit of time, they are not going to be feeling anxious, because we keep toys there, and there are books for the older children. So the children are engaged. And also this is a place where we keep clothes and masks and cap for the parents, especially when we take them inside the theatre for induction. Now, the start of anesthesia is basically called the induction of anesthesia. Inducing means it's actually putting the child to sleep. And what is special about the pediatric induction is basically we allow the parents to be inside. If it's a very small baby or if it's a very older child, very similar to the adult, we take them straight into theatre. But these in-between group children who are anxious, we allow the parents and we encourage the parents to be present during the induction. Now, as I mentioned, it's not safe to take the parent straight into the theatre area because of the sterility. So that is why we have this in-between kind of a faced area called the induction room. So this is, again, you see, very child-friendly for the child. When they come in, they are very happily looking here and there. And we do have some toys also here. But how is it different from the patient holding area? It's because we have medical supplies here, which means we can anesthetize you. There is a full anesthesia workstation. We do have IV supplies, and also we have, airway equipment, suction, everything. So you can do minimal procedures here, for the child along the parent being present. Now let's have a look at how Kevin is being put to sleep with his mother being there. So you can see Kevin's mother there, happy that she is accompanying. You can see with all the toys how he is allowing the mask to be applied to his face. And you can see that we are starting with the anesthetic gas, oxygen and nitrous for our inhalational induction. And you can see the slowly the concentration of the inhalational anesthetic sevoflurane is being increased. Now because a mother is there and the child is playing with the toys, Kevin is not actually making a fuss, and he's allowing us to put the mask on. And you can see that's our anesthesia technician. You can see that slowly, with every 3 to 4 breaths, he's increasing the concentration of the anesthetic. And if you slowly start looking at Kevin's eyes, you will see that he's becoming sleepy. So we can see that Kevin is completely fallen to sleep, playing with the toys with the mother by the side. So this is how we do most of our pediatric induction. Once a child is induced, then only we put the IV line, we connect the monitors, we ensure that the eyes are taped, because when you do any airway management, we don't want the eyes to get hurt. And we also administer IV anesthetic and place the airway device. So all this happens only after the child is induced. And once a child is induced, we actually send the parent outside, and then after that we do all these procedures. The next important thing is the airway management. Now airway management, most of the children and babies, if you provide anesthetics and muscle relaxants, they stop breathing. So we need to provide oxygen, and we need to ensure that the carbon dioxide is removed. So for that we need to place the airway tube. So this airway tube can either be an endotracheal tube which actually goes through the vocal cords, or it can be the laryngeal mask airway which stays above the vocal cords. Both these airway gadgets, they have their own advantages and disadvantages, but basically any smaller surgery where there's not much of relaxation required and where there's not much of head movement is required or position change is required, we go in for the laryngeal mask airway, which is very easy to introduce and it is safe. But on the other hand, if it's a very sick child, expected longer duration of surgery, very small babies, as well as there is a need for postoperative ventilation, then we need to place the endotracheal tube. Now both of it, you need to ensure that the correct size is available and these tubes are working before you introduce. Next, after the airway tube is one of the gadget is placed, next will be the maintenance of anesthesia. Most of the time we use the inhalational agents, that is either halothane or iso or sevoflurane. We also use, if you're not, in some centers for some surgeries they don't use because these agents have their own complications. Then we go in for intravenous agents like propofol, which is very commonly used. You can give it as a continuous infusion for maintained anesthesia. Now along with this, we also use muscle relaxants and opioid analgesics. Now, next we need to know how Kevin's, physiological status is, whether his heart rate is fine, whether his oxygen saturation is okay, blood pressure is okay. So we always do these ASA standard monitoring for all type of surgeries, whether it is a minor to very major extensive surgeries. Okay, so ECG with the heart rate monitoring, saturation monitoring, blood pressure, we always measure core temperature. That is, we put the temperature probe through into the nose or the oral cavity rather than the skin temperature, and also end-tidal carbon dioxide. Now, in addition to this, if it's a very sick child or if it's a major surgery, we do invasive monitoring like intra-arterial blood pressure, where we put a cannula into the artery and measure beat to beat. We can do transesophageal echo. We also monitor urine output, etc. So all these are based on what type of how sick the patient is, as well as how extensive the surgery is going to be. Now, IV access, as I said, we start the IV cannula after the child goes to sleep. Now, there are cannulas coming in different colors, sizes. So, we choose the cannula based on the age of the child as well as what type of surgery. Now, 4-year-old Kevin, probably it is only a moderate surgery. It's not going to be much blood losing. So, I will just go in only for a 22 gauge IV cannula. If it's a very smaller baby, then probably I'll go for 24. Now, if it's a surgery where I have to give lots of blood or fluids, then I might have to put in 2 or 3 lines and not just stay with just one line. Now, central line is something what in discussion with the surgeons we put it in if they anticipate very stormy post-operative period, or intraop also if I have to do lots of blood sampling, or if I have to give inotropes, then central line is put in. Remember, if you're putting lines in the legs, make sure that you have extensions like 100 centimeters extensions which are connected and brought up, so that in between you don't have to search for the line between the drapes. And these are called if you look at this picture, these are the vein finders. Basically, it does a trans illumination for for children with difficult IV. This is something which helps us in locating the IV line. Now, fluid, mostly we use the balanced crystalloid solutions like normal saline or ringer lactate. And fluid, most of the time you all know that it comes either as a 500 ml bag or it comes as a 1000 ml bag. So now imagine a child who is 5 or 10 kg or even 20 kg. This is going to be excessive fluid. So what we use is something called the burette system. So we attach this, this end into the 500 ml bag, and we take only about 30 or 40 or 50 ml based on the weight of the child, and then we run it. So in that way, even if the clamp by unexpectedly somebody opens it, that only that the calculated volume will go in, and it's not that entire bag which will go into the child. So burette system is something which should be definitely used for children, especially for low weight children. Now, in addition to that, we also use these connectors which through which you can actually give in the drug, but make sure all these are de-aired and kept, because lots of these children come with ASTs or BSTs, which means there are connection in the heart, and anytime you you put in an air bubble, there is a chance that it can go into the systemic circulation. Now, dextrose containing fluid earlier used to be given very routinely during the intraoperative period, but now we do not do that. We avoid dextrose containing fluid. On the other hand, because the fasting guidelines, we actually keep the child fasting just appropriately, as well as we always check sugar also. As after we start the line, just with that minimal amount of blood which is there in the stillet, we check the blood sugar, and only if it is less than 60, we actually consider giving dextrose. Very small neonates or very sick babies who have been on dextrose infusion, then probably based on the sugar, we will alter the dextrose, the infusion rate. But generally, we do not use dextrose containing fluid intraoperatively. Now, positioning is something again which is very important for an anesthetist, which and I always think that positioning is a shared responsibility of both the anesthesiologists, the nurses, and the surgeons. And Dr. Susan had extensively gone into it, so I'm not going to repeat that. Now, temperature is again something which is very, very important because, as I had mentioned, children are different from adults. Their skin is very thin and they have a large surface area as compared to their body weight, and also because of the less subcutaneous tissue and fat, they lose temperature very quickly when they come into this colder atmosphere. So the smaller the child, the more heated up the room is going to be. And if you see, this is basically the infant radiant warmer. So basically the whole atmosphere here is very warmed, because in a very small baby, especially when you're going to intubate, when you're going to put lines, the child is going to be exposed. So at that time, placing the child in this warm atmosphere is something, will help prevent hypothermia. Now, the smaller the child, the extensive the surgery is going to be. And if it's lots of areas, say for example a major laparotomy or a hepatectomy where there's a huge surface area which is going to be exposed, then you need more than one warming method. You use a combination combination of various warming methods to ensure that the child does not become hypothermic. Now what you're seeing here in the picture, basically this is the antibody, this is the ready-made antibody warmers through which you can blow the warm air and the child lies on top of it so that the hypothermia is less. Now, because those sheets are expensive, in our institute, we make these custom made, we take a clean plastic sheet and we, do these kind of partitioning in such a way that there is, when you blow hot, the warm air through one of the end, it actually travels on all the sides. And here we make lots of small holes on top of it. So, which means the warm air escapes here, and when the child lies on top of it, that is, the child is surrounded by this. Now, beware, you cannot put the child straight on the plastic. So, we use these kind of sheets and the child lies on that, and this sheet is constantly warmed by the warm air. Now remember to check the temperature, because you can actually cause more harm and can cause iatrogenic hyperthermia if you're not careful about your warming devices, and ensure that you're measuring the temperature throughout the period. Now, in addition to all these warming methodology, we can also warm the child's, small, especially for smaller babies, the smaller clothes, the smaller, soft pads, what we are going to put on the hands and the legs, even those can be warmed, especially in areas or in mission hospitals or rural setups where you don't have these fancy gadgets. These are, some methods by which you can keep the child warmer. And we also use warm IV fluids. Now, pain management is something which is very important for anesthesiologists, and we use something called the multimodal pain management. That is, we use drugs from different groups, and so the least amount can be used, but you use a combination. Say, for example, acetaminophen is something which is very important, and we give it IV. And opioids, again, we use very commonly inside theaters, as well as wherever we can put in local, we do put local. I know Susan, as well as other surgeons will agree that sometimes it's very irritating for them to sit and wait for the block being done, but remember that local should be a part of any analgesic technique what we use. So this is the pain management technique. And nowadays we have ultrasounds which are available in most centers, and ultrasounds will ensure that your block is kind of safe, and you use very minimal local anesthetic as compared to earlier these conventional techniques where they just go by the landmark. So you have to use a large volume of local anesthetic. Now all that has come down. Now, once the surgery is done, we ensure that the child is basically, the temperature is normal, all the vitals are stable, and then after that we cut off the anesthetic and we pull out the airway gadget, whether it's an endotracheal tube or it's a laryngeal mask airway. And after that we transfer, once ensuring that the child is stable after extubation, we transfer the child in this recovery position, that is in the lateral position. Two things: one, it will prevent the tongue from falling back. Second thing is, it will, any secretion of blood or anything is there in the mouth, it can actually drool outside rather than child aspirate on it. And always the anesthesiologist has to accompany the child from the theater to the PACU, and along with that we take all the anesthesia records which are completely documented, as well as syringes, especially some opioids, as well as a flush syringe to the PACU. Now in PACU, Kevin, after the surgery, will be handed over to the PACU nurses, and it's very important to give a brief summary of the preoperative and intraoperative period. Like preoperatively, any concern like the anesthesiologist had, like you can say a recent respiratory tract infection, or a child who had a AST or a VST, something which is significant. And intraoperatively, what was it like? I gave a general anesthesia with a laryngeal mask airway, and I put in a caudal for analgesia. So that will be your complete anesthesia plan what you had done. And similarly, any concerns you had intraoperatively, like say for example, Kevin had a brief episode of hypotension or a bradycardia, or the temperature was only about 35.5. So something like that you can mention if there had been any complication. Also you can tell them what you need to monitor. So very important, the heart rate, the blood pressure, the saturation, as well as the breathing of the child has to be documented. Now how do you get this breathing pattern? When you apply the ECG with the abdominal movements, you get this breathing pattern. So it's very important to ensure that all these vitals are stable before you leave the PACU and go on to your next case. Now next, Kevin has to be, the feeding plan also has to be communicated to the PACU nurse. Now, what are the important things you need to watch out in the post-operative period, which are common complications in children? One is a stridor, and you can definitely make out a child who is stridorous. You can see that, you can see in this little baby, you see how the chest in drawing is there. They'll have a high-pitched cry. There'll be flaring of the nose. There'll be a tracheal, in drawing. So all these are very, classic features of stridor, which is something you need to be watching out for, especially if the child has had a preoperative infection or a respiratory infection in the last 2 weeks. Now, along with the stridor, there are other common complications like, respiratory depression. The child would have still had the effect of the anesthetics as well as the opioid analgesics. So always monitor your respiratory rate in addition to your saturation. So don't go only by the saturation, because what happens if you're providing oxygen for a child, the saturation does not drop to dangerous levels very, very late. Whereas if you are measuring the respiratory rate, then you can pick up the respiratory depression much earlier and can treat the child even before the saturation drops. So hypoxia is something what you really need to watch out for. Next, children can develop bradycardia. So it's again important to watch out for their heart rate. And again, centers where you're not regularly doing children, when you're having, adults and child side by side, seeing a heart rate of 60 is very normal for an adult, but you can't see the same thing in a, say, 1-month-old child. Then it is almost a cardiac arrest for the child. So it's important to know what are your normal, limits, and so treat the child accordingly. Similarly, look out for hypothermia and hypoglycemia, because say hypothermia is again very common, because intraoperatively we nicely cover, we employ so many warming methods, but when the child comes to the PACU, then all those are immediately, the child is exposed to the cold air, and there is a high chance they can become hypothermic. Now, in addition to that, they can also have emergence delirium, that's agitation after waking up from anesthesia, or the child can cry in pain. So it's very important to differentiate both, because the treatment modalities are very different for pain as well as emergence delirium. Now, feeding in PACU, it's something what we regularly starting to do now. No longer children are kept feeding for a very long, fasting for a very longer time. So once the child is, so this is Kevin sitting up, and you can see his mother changed again and brought into the recovery room. And because Kevin did not have any abdominal procedure and he doesn't have any vomiting, we give him clear fluids to drink. And similarly, for very smaller babies, we ask the mothers to breastfeed in the PACU itself. And for children who cannot take orally immediately, what we do is we take gauze pieces and wet it with glucose and glucose containing fluids, and we just wet the lips with that, so that, or just the child can just keep sucking on that. So feeding is something which will help the child to recover very quickly and get back to normal. So this is feeding we start in the recovery room. So this was the journey of Kevin, right, starting from the preoperative period, intraoperative, as well as the post-op period. So before I finish, I would like to conclude by saying a child is very different from the adult, because basically their reserves are less and the metabolic requirements are so high that they desaturate or they become sick very quickly. So very important for the anesthesia team to be knowing the patient completely in terms of their assessment and their investigations, examination, and adequately prepared in terms of fasting and if required pre-meds, as well as arranging for adequate blood and products based on the surgery. Being adequately prepared in OR before you take the child inside, with clear airway management plan, as well as personnel to help, not just anesthesiologists but also anesthesia technicians if it's available in your center. And you should know what are the common complications can happen in the post-operative period, so that you look for it, you pick it up, and you treat it as early as possible, so that the child has good outcomes. Thank you.
Thank you, Dr. Anita, for that in-depth explanation about the anesthesia needs in the preoperative, intraoperative, and in the PACU. Thank you very much. And I'm sure she was trying to explain as much as possible. There's so much to explain, I know, and I hope we have got many new information from her presentation. Thank you very much. I have one question in the question answer session about whether the PowerPoint slides will be available. I just would like to say here. This is a recorded presentation. The recording will be available on the GICS website for you to review if you want. With that, I'd like to go to the next presenter. I don't see any other questions, and I think there's less time, so I will just go on to the next presenter now. I'd like to invite now Miss Anita Kriba, who's a professor and nurse manager in the OR, in pediatric OR. She's been there in the OR as a nurse manager for 14 years, and she has completed her master's in medical surgical nursing. And her area of interest is staff development in OR and also improving patient care in PACU. She's passionate about teaching, student nurturing, and also learning from others, each other. So I'm indeed very glad that she is here to talk about PACU care and the discharge from PACU. With her experience, I'm sure she'll be able to bring out some important and practical points that we need to remember when we take care of children in PACU. Over to you, Anita.
Is my screen visible, ma'am?
Yes, it is. Go ahead.
Thank you for those kind words, Vinita, ma'am. Thank you for the opportunity that GICS has placed before us. So I'm here to talk about discharge from PACU. Just a few minutes back, we listened to Dr. Anita talk about how much a child goes through intraoperatively in terms of anesthesia. And a few minutes back, we also heard from Dr. Susan how uh, what all the child goes through in terms of surgery. These two have a great impact on children. So when they come to PACU, which is the post anesthesia care unit, they are left with us nurses to care and give comfort. So I will be talking to you today on discharge from PACU. PACU is a precursor for ICUs. Like how monitoring is very important in ICUs, the same monitoring is quite important in the PACU as well. What are we monitoring? We are monitoring the vital signs to ensure that the child is stable. Also, we look out for uh, complications related to post anesthesia. After anesthesia, there are complications that are very significant that can affect the child. So we are looking out for it. And these monitoring in PACU helps us to identify complications early and act quickly and be protective of the patient who comes to our hands. So studies have shown that emergence delirium occurs in about 12 to 13% of children, typically identified within the first 30 minutes of recovery and usually resolving spontaneously within 5 to 15 minutes. And 10% of pediatric patients experience respiratory complication. And it's said that 8.9 to 42% of the children experience postoperative nausea and vomiting. We, in our PACU, have experienced children undergoing all these complications per se. We have divided the PACU phases in two. One is the intensive monitoring phase, that is, once the child comes into the PACU until the child wakes up from the effects of anesthesia. The second one is the discharge preparation that we take to ensure that the child is safely handled um, in the wards and back at home as well. So, the intensive during the intensive monitoring phase, one nurse is exclusively assigned to take care of the child's vital signs, and every 15 minutes the vital signs are monitored, and uh, complications are looked out for, both in terms of anesthesia as well as surgery. And once the baby awakes, the mother is invited, like how Dr. Anita told us, and the child is handed over to the mother. But the nurse also stays uh, besides the patient, but the monitoring goes down very drastically. So if we are monitoring for every 15 minutes, after an hour or two, it becomes every half an hour. And the mother is encouraged to look out for complications. And every 15 to 20 minutes, the nurse checks with the mother of such complications. So these are the two phases that we um, uh, encounter every day with the children who come into PACU. Since my topic is discharge, and we have some criteria that we need to know of how to discharge a patient in the PACU. But before that, we need to understand that nurses are um, can, are not authorized to discharge in our institution. It's the anesthesiologist who oversees before discharging the patient from the PACU. There are three P's and three N's that we need to remember. The three P's are physiologic, when the patient can be discharged when the child is physiologically stable, when the child is pain free and comfortable, when the PATS, that's the post anesthesia discharge scoring system, is well within the range. And there are three N's that we need to keep in mind to understand if the patient can be discharged, the child can be discharged or not. It's when there is no new neurological deficits, no post-operative nausea or vomiting, no bleeding or oozing from the surgical site. Now, when we decide that the patient, when can we decide that the patient is ready for discharge? So when the child is able to have a good SpO2, and when there is no airway obstruction, when the vital signs are stable, when this child is fully awake or crying or appropriately behaving for the age, and when the pain is well under control, we can say that the child is physiologically stable and the child is ready for discharge. And the second thing that we need to look out for is pain and comfort that of the child. Adequate pain relief with oral or IV medications will be administered in the PACU to control pain and promote comfort. Um, but it is wise that we do not discharge the patient after administering a pain medication, and only when the pain score is less that we would also discharge the patient from child from the PACU. Our assessment would continue using appropriate pain scales depending on the age of the child. The children below 7 years, we use FLAC scale to assess the pain, and over 7 years, we use the visual analog scale to assess their pain scores. As I previously said, the next P would be post anesthesia scoring system. There are two scores that are helpful to decide whether the child is ready for discharge or not. One is the Aldrich score. The Aldrich score is is a 10-point score where it includes the activity, respiration, circulation, consciousness, and oxygen saturation. If the score, Aldrich score, is more than 9, that's when we say that the child is ready for discharge. The PAD score is similar to that because the PAD score also is a 10-point score where we again say that any score above 9 of PADs, the child is ready to be discharged. So, vital signs, activity, nausea, pain, surgical bleeding are components of PADs. This is the modified Aldrich score that I was talking to you about, which has 5 important aspects, and each aspect, the maximum score is 2, and the total score is 10. The child is safe for discharge when the score is above 9. This is another scale that I was saying about. The total PAT score is 10. Score above 9 is considered fit for the child to be discharged. Another discharge criteria is no new neurological deficits. So, when the child is awake, we need to observe for appropriate motor functions. Our nurses also look out for drowsiness and agitation. Many of our child would cry, and most of the time we think that the child is crying because of pain, but we realize that it's the emergence delirium that causes them to be agitated. So we look out for them for that, and we also look out for neurological deficits if the child has gone through a surgery with blocks and so on. When there is no new neurological deficit for the child is ready to be discharged. Another aspect that we need to look out is nausea and vomiting. As Dr. Anita was mentioning about lots of medications, these medications have an effect on the vomiting center, and there are children who actually have post-operative nausea and vomiting in the PACU. We have not seen many in the recent past, but the children can experience post-operative nausea and vomiting in the PACU. Uh, we cannot transfer a patient out without the nausea and vomiting. Only when we can transfer the patient out only when the post-operative nausea and vomiting are under control. Also, like how Dr. Anita was rightly saying, we initiate the oral fluids for children, and if they are able to tolerate well, the child is ready to discharge. And we also look at the dressing of the surgical site. And if there is no soaking or bleeding or oozing, we kind of decide that the baby is ready for discharge. In the PACU, apart from looking out for and monitoring the patient for post anesthesia complication, we also look out for the needs. As we all know, every age has their own needs, and their age specific needs are also met in the PACU. One of the important thing that we do in our PACU is involve the parents, and their presence gives the child an emotional support and comfort that hastens the discharge process. Again, as we know that there are 3 P's and 3 N's as criteria for discharge. When is the patient or the child ready for discharge? When the child meets the discharge criteria, and when the child is able to tolerate the oral fluids, and when there are no unexpected post-operative complications in the PACU, the child is ready for discharge. We also talk about the pain medication, post-operative complications, the signs and symptoms, and when the child can um, be started on soft solids to the mother while the mother and the child are being discharged from the PACU. There are delays that can happen because of vital reasons, the delay for discharge, when the vital signs are unstable, when there is persistent drowsiness or confusion, when there's poor pain control, excessive nausea and vomiting, and respiratory complications, there is a delay in discharge from PACU. Most of our children are transferred from if they are neonates, they are transferred directly from the OR to the neonatal ICU, and the children in the PACU are transferred to the ward. And if there are some complications that happen in the PACU, the children are transferred to the pediatric HDU and ICU respectively. So here is a case study that I would like for us to go through and decide whether, if everybody can put it on the chat, it will be nice. So I would be reading this case study and you let me know whether the child is ready for discharge or not. This is Emily for us, 4 years old, 16 kgs, had undergone tonsillectomy and adenoidectomy under general anesthesia with sevoflurane and fentanyl. 1 hour post-operatively, despite initial stability, Emily begins exhibiting the following issues. There's in stridor, there's desaturation that has happened, there's agitation, the child is crying, there's a heart rate increase to 130 beats per minute, and the flax scale remains 7 on 10. This continues even with intervention. Now, where will we transfer the patient? Is one question, and will we transfer the patient at all is the second question. Kindly put your answer on the chat, please. Okay, so to take home, there are 2 phases of recovery in PACU. Any child or any patient would undergo. That's phase 1 and phase 2. We need to intensively monitor the child in phase 1, and we have to involve the mother in phase 2. There are 3 P's and 3 N's that can be applied for discharging a child from PACU that we saw. And the most common reasons for delay from PACU are unstable vital signs and respiratory complications. Apart from that, we need to understand if we have to discharge a patient from the PACU, our nurses must be well versed and trained in reading and monitoring the patient using ALRIT and PATS scoring system. And these two help us to assess the readiness of the child from the PACU. And the most common transfer units for PACU will include the ward, the NICU, PHDU, and PICU. If there are any questions, kindly place them on chat. Thank you.
Thank you, Anita. If you cannot access chat, there is a question answer side also, part also. Maybe you can put the answer or questions in that. I hope you know. Actually, Anita asked a very good question from the case study, just to make us think. Probably we don't have enough time you didn't have enough time to think about the discharge and correlate with the discharge criteria that we listened to. But I'm sure there were important points shared on the criteria for discharge and what instances that we need to to decide not to or yes to discharge from PACU to ward or to the intensive care units if needed. So thank you, Anita, for that presentation and giving us important points and tips as to what we need to observe in PACU, what we need to address, and then how we have to prepare for discharge. Thank you once again. I don't see any yet. So we'll just wait. Now we'll go on to the next person, the last person, panelist, who will share on anxiety and fear in children who are undergoing surgery. So I just would like to take a few minutes to introduce the panelist, Esther Kanti. She is an associate professor and nurse manager at the Pediatric Nursing Department, Christian Medical College. She has completed her master's in pediatric nursing, and her area of interest is pediatric surgery and developmental pediatrics, and she's interested and is a quality improvement manager as well. She's very passionate about giving care to children, especially surgically ill children, and also now in developmental pediatrics. And she has been also part of adolescent pediatrics earlier. Now she will talk about addressing anxiety and fear in children who are undergoing surgery and important points to consider. Over to you, Esther.
Thank you, ma'am, for your kind words of welcome. Ma'am, is my slide screen visible?
Yes.
So my talk is titled Addressing. I'm sorry, ma'am.
Yeah, we got.
My talk is titled Addressing Anxiety and Fear in Children Undergoing Surgery. The overview of the talk would be, I would introduce about what is preoperative period and anxiety, the risk factors, what is stress, the manifestations and implications of preoperative anxiety, and the approaches to preoperative anxiety, and finally about the research that was done in CMC Vellore on preoperative anxiety. So as discussed earlier, perioperative period consists of the preoperative, intraoperative, and postoperative period, whereas the preoperative period is the period which begins with the decision to proceed with the surgical intervention until the patient is being transferred to the operating room. Predominantly, very commonly seen in children, about 65 to 80% of children experience preoperative anxiety, and it is more harmful in children than in adults because children experience fear of unknown. So they have no idea what would be the outcome of the fear, and that hinders their ability to adapt to very unfamiliar medical environments in a hospital. And also we should remember the children, given the higher amount of surgery performed in children, it is really important for us to optimize the outcomes both for children and the parents, because it is not only the children who experience preoperative anxiety, but parents as well. So some of the risk factors for preoperative anxiety in children are children who are younger, especially 1 to 5-year-old children, children who are shy, inhibited, children with a higher IQ who understand a lot of things, children who have a lack of good adaptive abilities, and when they've had previous experiences of surgery or hospitalization, some of them, if they have had a bad experience, then they are again at risk for developing preoperative anxiety. And parents, if the parents are anxious themselves, and if they have had a bad healthcare experience, and their coping styles plays a role in the kind of preoperative anxiety they experience, and the environment in which they are, both home environment and the hospital environment, also poses as a risk factor. if we look at the stress, the human body responds to surgical stress with through a series of hormonal, immunological, and metabolic changes that contributes to this global surgical stress. And if we see specifically, the pituitary adrenal axis is activated, which increases the glucocorticoids, and that makes the children more susceptible to infection. So apart from the surgical complications, even stress adds to the complications and their susceptibility to infection and injury. And children are more particularly vulnerable to this stress because of their limited energy reserves, larger brain masses, and their requirements for glucose, which is more. So some of the manifestations of anxiety in children are the feeling of tension, apprehension, nervousness, irritability, worry, fear, increased blood pressure, increased heart rate, and increased sensitivity. And what happens when children are actually anxious? As discussed by Dr. Anita, it prolongs the induction time of anesthesia. The anesthesia duration is increased, and the recovery time is also increased. And this also reduces the pain threshold. This makes the children more vulnerable, so they require a lot of postoperative analgesia, increased postoperative pain, and this can actually affect the outcome of the surgery and the rehabilitation. The other implications also in the long term, they might end up with new onset enuresis or secondary enuresis, feeding difficulties, apathy, withdrawal, sleep disturbances, nightmare, crying at night, delirium that we have discussed, heard over and over again, separation anxiety, tantrums, eating disorders, and increased fear of medical staff. This is not just the immediate postoperative period, it can extend up to a year after the hospitalization or surgical intervention. This makes it really important for us to actually address the preoperative anxiety promptly so that we do not have children ending up with long-term complications, which will actually affect their growth and development in the long run as well. So there are four methods of approaching the preoperative anxiety. One is the behavioral approach. Second is the educational approach, pharmacological, and complementary and alternative medical approach. So if we look at the behavioral interventions, in the 1960s, the children were given orientation to our narrative information was provided. In the 1970s, modeling techniques were used by role rehearsing, by using dolls or viewing a video. By 1980s, coping skills were taught along with the modeling techniques. Currently, what we're using is the coping strategies, modeling, and parental presence during induction of anesthesia. So some of the coping strategies or teaching and development of coping skills that can be used for children are: one is distraction. Distraction is a method of diverting attention away from anything which is actually distressing or a threatening environment. Especially for children, currently it is the perioperative anxiety. So what can be done is these children can be taught activities and they can be rehearsed before procedures, and it'll be nice if parents are used as coaches so that parents will be able to distract these children. Examples of distracting activities can be providing toys, playing games, and they can be provided in the ward, in the waiting room, and in the recovery areas. The second technique is relaxation. Relaxation is found to be effective in alleviating the preoperative anxiety in children as young as 4 years of age. So methods of relaxation techniques can be diaphragmatic breathing and progressive muscle relaxation. So in diaphragmatic breathing also includes conscious breathing. So you tell children to count in, count out, and be aware of, tell them to inspire, tell them to take a deep breath. So they are aware of their inspiration and expiration. This actually helps in relaxation. And another method is progressive muscle relaxation. This is basically done by controlled relaxation of targeted muscle groups. So you specifically mention a certain limb or certain groups of muscles and ask them to consciously relax. This in turn reduces their anxiety through relaxation. And the third method is guided imagery exercise. Here we can tell children to recall or reconstruct certain experiences which are actually sensory and affective. Like we could give them some visual experience, visual, auditory, olfactory, emotional stimuli, and they can recreate a mental image. Thereby, they are actually diverted. This helps in reducing their anxiety and acts as a coping skill. Another technique would be to use a live or filmed model that demonstrates coping strategies. All of these can either be directly provided by a healthcare provider or a parent, or a video could be used, or an audio recording of any of these can be shown or given to these children to use them. The next technique is modeling, where role playing can be done, or video depiction of another child undergoing a similar surgery also can be performed. The next one is the presence of parents, parental presence during induction of anesthesia. Dr. Ranita told us very beautifully about parents actually being present, and which definitely reduces the anxiety of children undergoing who are being induced or given anesthesia. Some of the benefits are it reduces the need for preoperative sedatives, definitely. Avoiding the fear and anxiety that may occur on separation to the OR, and it increases the child's compliance during induction. And sometimes there are some disadvantages or objections, because there can be a concern about disruption of the OR routine. The ORs can be a little crowded, and sometimes if the parents are actually really very extremely anxious, they can pass on that anxiety to children. That will actually prolong the induction, and it adds stress to the staff around. So some of the advantages of these methods are they are cost effective, they are minimally invasive, and they carry a very low risk for adverse effects, and they contribute to its continued and widespread implementation. We are actually implementing many of these in our setup as well. And the second approach to reduce anxiety is the educational approach. So here we provide information and preparation which are relevant to the surgical procedures and outcome. So few things that could be done are a tour around the operating theater, and the PACO could be given. It could even be an actual virtual tour, orientation to the medical equipments and their functions, the equipments that would be used, the masks, the instruments, the lights, all of those could be the pictures, or a video of those could be shown as well. Description or visual depiction of the preoperative procedure could be done, and explain to the parents and the children. If they're older children, they're definitely required to be told the course of surgery. What happens? They enter into the first thing. They're taken to the induction room, and then they are after they are anesthetized. They are taken into the theater, and once the surgery is over, they are taken to the PACU, and then they are brought back. So you tell them the entire course of surgery, tell the people who will be involved, and describe the sensory aspects. What is the feeling? When will they actually stop feeling? And when they wake up, what are the experience they might experience in a PACO? All of those needs to be told as well. And it is ideal that the preparatory information should be given at least 5 days in advance for children who are more than 6 years old, and not more than a week in advance for children who are less than 6 years, because they tend to forget if it is told very early to them. So some of the age-specific interventions that can be done to these children are, for infants, we can encourage the parents to bring some comfort items like a blanket, their favorite pacifier, or music that they listen to, or a familiar item from home that reduces their anxiety. For toddlers, it is ideal to use very simple and gentle language to describe the sensory details, or like feeling, touch, and smell. And it is really important for us to remind the child that the surgery is not a punishment for being bad, because often they blame themselves, or they think it is a punishment because they've done something bad. Preschool children as such, it is important for us to use simple words without too many details, and include sensory information. And here again, these children require an assurance that the reason for surgery is for them to get well, not because that the child did anything wrong. So it is important for us to reinforce and tell them over and over again that we want the surgery is being done because we want the child to become well. For a school age child, as healthcare professionals, we need to be open to answer questions that a child has, and try avoiding threatening languages. Like The words like cut, incision, short, they're all very threatening to school age children. So it is ideal for us not to use such threatening language, and don't bribe children as well. If you don't hold, like example, if you don't hold still, the nurse will give you an injection. So those things can be avoided. And for adolescents, encourage them to make their own choices, include them in the plan, and give them honest and complete explanation about surgery. And the advantages of education are, it addresses the gap in the understanding of patients and family, and gives them an opportunity to learn about the process, and helps us also to build a rapport with the parents and the children. The next one is the pharmacological interventions. We did learn a few of the pharmacological interventions. So I would like to skip those points. The commonly used drugs are midazolam, tricloral, and Valium. We don't give that for everyone. We only give for children who actually require or who request. And the next one is complementary and alternative medicine approach. These are not very widely used, but we could actually use them. Music therapy is one thing which is low to no cost, and it is easily available, and children have an already existing music playing device. So when such things are easily accessible, then music therapy could be used to reduce the anxiety. Hypnosis, acupuncture, and acupressure, all these three do not have a lot of literature. There is very scanty literature to talk about hypnosis, parental acupuncture, and patient acupressure. But there is some evidence to talk about parental acupuncture, which reduces their anxiety, and when they are less anxious, they tend to help children reduce their anxiety as well. So these are the other complementary and alternative medicine approach. And there was one study that was done in CMC Vellore. This was done in 2019. The credit is to Ms. Lipsa, who was an MSc nursing student who conducted a study to assess the effectiveness of virtual animated film on preoperative anxiety in children, where she found she did a pre-test to assess the anxiety. And then for the control group, she did show them a 4-minute 42-second video before the day of surgery, and post intervention anxiety scores was significantly low in the experimental group, and it was significantly high in a group which did not, in the control group. If time permits, I could show the video, ma'am. Can I show the video, ma'am?
Yes, you can show. A 2 minute, I
Okay.
think.
This was the video that Ms. Lipsa played for the students, for the parents and the children, just the day before surgery.
Hello everyone, my name is Ben. Today I'm going to tell you my story of how I spend my days in the hospital. Some days before, I just fell down and the doctor examined me and he said that I need a small operation. So my mother and my sister were with me in the hospital. I could see so many other children in the hospital with me. I saw different televisions without any cartoon, and also I saw different things like a stethoscope. I also met nice nurse who tied a band around my wrist which had my name, my number, and my birthday as well. I had to wear it all the time as I was instructed. She also checked my heart to see if I was fit for the operation. She also tied a cloth around my arm to check my blood pressure. She said I also have to check my weight and my height. I think I'm quite tall. So I was instructed not to eat anything and ask before I could drink something to my mother. Now I'm perfectly ready to see the magical room where I'm going to get all right. Me, my mother, my sister, and uncle. We all went through a big door and we entered the elevator. The elevator was a cozy place. When the door opened, I came out of the elevator and the ride was like riding a car. Sometimes later, I played with my mother in a tiny room before going into the operation theater. And Dr. Auntie came and she read my name,
We can stop and explain, I think, and finish.
and I was moved into the theater where I could see the magical door.
This video completely explains about the OR, the things that are there, and how she would be, how anesthesia would be given, and yeah, wake up later in the PACU, and her experience in the ward, and finally going back home and going back to school. So yeah, these are my references. So this video continues to be played in the ward in the evenings for the children who are usually operated the next day. Thank you, ma'am.
Thank you very much, Esther, for highlighting the importance of addressing anxiety. I think anxiety and fear, if we don't address, then whatever we do may not be very effective for children. And definitely, we have seen that the post-operative course can be stormy if their anxiety is not settling. And it starts right before surgery, right at the time when the decision is made itself. So that's very true. Thank you, Esther, for explaining that in detail. With Esther's presentation, we have come to the end of our webinar, and I just would like to thank all the panelists today for presenting their aspects of interoperative care. I'd like to start with thanking Daisy, and then Dr. Susan, Dr. Anita, then Ms. Anita, and Ms. Esther. So thank you all for spending your time and making an effort to present some of the practices that we have here in our country in CMC, and also some of the evidences from the literature. I don't see, as far as I can see, I don't see any questions or any comments in the chat, and neither in the question answer session, except some comments on presentation. Are there any questions now? Maggie, can we open the session for them to ask some questions orally, if it's okay? Just another 5 minutes and we'll finish.
They can put their questions in the Q&A section,
Okay.
or they can raise their hand and we can allow them to speak.
Yeah.
If they have to raise their hand, and then I can allow them to talk.
Yes, that'll be good. If anybody has any questions or any comments, you can place your hands. Okay, everybody seems to be quiet. I'm not sure whether they have understood all, or we just assume that it's all is good. Thank you all for joining at this juncture. I just would like to thank all the participants from different countries who are here. So, thank you all for joining and spending more than 2 hours with us on this topic. I also invite all of you to join GICS nursing group and become members of GICS nursing group. So we can move forward with many other activities as well. Webinar is something that we have started and we are doing for quite some time, and we hope to continue more webinars. So look for more webinar announcements and join whenever it is possible. Thank you once again, and I just would like to say good night or good morning or good evening, whichever part of the globe you are in.